Hello, and welcome to the Pulse of Manatee, brought to you exclusively by Manatee Educational Television. I'm your host, Dr. Srini Iyengar, a cardiologist at Bradenton Cardiology Center. Did you know cardiovascular disease accounts for more than 800,000 deaths in the U.S.? That's about 1 in every 3 deaths in this country. But the good news is in many cases, heart disease can be prevented and managed. This month, February, has been designated as Heart Disease Awareness Month. And today we have gathered an expert panel to discuss risk factors for heart and vascular problems and the most efficient ways of maintaining a healthy heart and vascular system. Let me introduce our guests today. To my left, we have Dr. Bob Kozer. To the left of him, we have Dr. Howard Hermans. And to the left, we have Dr. Vivek Kumar. We have a great panel here today, guys, and I want everyone to really soak in some of the questions and get the discussion going here. And we're going to start first by Bob. I'm going to talk to you first. Now, being a family practice physician, a physician that sees patients in the general aspect of medicine, what would you say to a person that walks into your office and says, I have a history of heart disease in my family, what do I need to be checked for?
Well, the first thing that I do is look at the patient in a wholesome type of view. What kind of cardiovascular risk factors does this one patient represent? Do they have hypertension? Do they have high cholesterol? Is there obesity? Is there a chance that the patient might be diabetic? Is there a chance that they might have a heart murmur or a carotid bruit? Or do they have diminished pulses in their legs? Do I need to put this patient on a diet to have them lose weight, an exercise program? Does their blood pressure need to be controlled? And blood pressure is very, very tricky. More than half of the patients that are treated with blood pressure medicine are not getting to goal. And very few of the patients that have high cholesterol are willing to take a statin drug, which have been proven to be life-saving in many cases.
And Bob, I love the fact that you said the one word which is critical. You said wholesome. You take the systemic view of the patient, and that's what I'd like to have patients know at home watching right now. When they come to see you, they need to know that it's not one issue, it's not just the heart, but it's the body.
You have to look at the patient as a whole. What's their family history? What's their makeup? What kind of work do they do? What kind of stress environment are they having? Do they have a drinking problem? Have they had a drug problem? Is there diabetes in the family? Do I need to send the patient for blood tests to make sure that they don't have underlying diabetes that's remaining silent for all these years?
And that's exactly the risk factors that lead to worsening heart and vascular problems. Now, Vivek, if the patient is found to have more issues beyond the diabetes, hypertension, and potentially the family history, and they're actually having some symptomatology or some issues related to the heart and vascular system, what do you do as a cardiologist when you see these patients in your office?
Well, the first thing I do when I see one of these patients that maybe Bob sends over to me to evaluate is go through the whole risk factor profile all over again. So I hit these 5 major risk factors. Their hypertension, their diabetes, do they use any kind of tobacco? Do they have a family history of heart disease? That's 4 of the 5.
But those are 4 very major points.
Okay. The tobacco one was the one that I really wanted to focus on, and it's just because it doesn't matter what kind of tobacco, what kind of nicotine they get in their system, all of it damages their arteries, whether it be the heart arteries, the ones up in the neck, the carotid arteries, the ones that Howard's going to see in the legs also, these peripheral vascular disease patients. The nicotine's going to hit all of them, so I really harp on diabetes, on tobacco, and making sure that they get every bit of tobacco out of their system.
And I think that's such an important point. We cannot underemphasize to everyone at home watching the dangers of that type of etiology to the body, the tobacco. But Howard, as a vascular surgeon, I think you can comment extremely well about the patients that you see with this history. What do you see when you see patients that come in with PAD, peripheral arterial disease, with smoking history? What's your main focus at that point?
Well, I'm always trying to get them to restrict their tobacco use. I'm trying to get them to eliminate it, and that's very difficult to get the patients to get on board to do that. I am finding the patients when they're near the end stages of their disease. So I am now going to try to ameliorate the symptoms that they're having. One thing that people don't realize is that the life expectancy of a patient with peripheral arterial disease is almost equivalent to the patient with lung cancer. They have they are limiting their life expectancy by with the peripheral arterial disease. That's why it's important to hit up on all the factors that we've been talking about, and then getting them back to a healthier lifestyle, getting them back to where they're exercising more, getting them back where their cholesterol level is being lowered, and trying to ameliorate the symptoms that they're having. If they're having what's known as claudication, the inability to walk because of blockages in their legs, trying to fix those blockages so they can get back to exercise, so they can lose that weight, so they can lower their cholesterol.
I think the important thing, too, for everyone watching is to know that if you are diagnosed with PAD, peripheral arterial disease, you're about 5 times more likely to have heart disease or a stroke.
Right.
So it's important that they realize just because they have a blocked artery in the leg doesn't mean that's all they have. There's
Right.
a chance it could be just this, almost the tip of the iceberg.
The same disease that affects the arteries in the legs affects the arteries in the heart, affects the arteries in the kidneys, in the eyes, in the neck. So it's a systemic problem. And so people, while oftentimes we put the patient into little categories, they have renal disease, they have hypertension, it's a systemic problem. And that's why when Bob treats them as a whole patient, it's important. Someone needs to look at them as a complete
Comprehensive way. And so now, Bob, let's bring it back in a full circle here. So the patient comes back to you now that we've gotten the vascular surgeon and the cardiologist comment on what we would do next. Let's start back at the basics. A patient, we talked about blood pressure. What is goal? What should people know what their blood pressure goal should be?
Generally, if a patient has a blood pressure greater than 140/90, that's called hypertension. And I attack hypertension very aggressively. And patients are often reluctant to take blood pressure pills. They're reluctant to take pills at all.
Absolutely correct.
And it's almost like pulling teeth sometimes to get these patients to take their medications.
And the thing is,
the goal is to keep it about 120/80. If you can get it down to that goal, that's great. Now, another really important point that Howard made is that this peripheral arterial disease, sometimes you can tell that they have peripheral arterial disease just if they have a diminished pulse in their leg or their ankles, but often you can't tell. You have to test these patients, especially the tobacco users, especially the hypertensives, the diabetics. There's a simple test you can do in the office called the ankle brachial index.
Yep, the ABI.
ABI. And I try and do as many as I can in my office. And as you know, because I've sent you so many patients,
Absolutely.
I am uncovering loads of peripheral arterial disease.
And the thing is, once you have that diagnosis of that PAD, then it opens a door to say, listen, there's other risks that are ongoing. Now, Vivek, if you see a patient, again, that comes in and says, hey, you know what? I've been told I have abnormal tests, but I don't feel that bad. But you know what? I have a family history. My father died of a heart attack. My brother has heart disease. Do I need a stress test, or do I need to get worked up more? What do you say in those cases?
Well, I will certainly assess all of those different risk factors and the cholesterols. I'm probably going to start with the blood work that Bob already drew. I may add some additional tests, particularly in that younger patient who's just thinking, oh, dad just had a heart attack, I better go get checked out. I might check some of these there are very specific inflammatory markers. There's a blood test called C-reactive protein. There's, we can check these other specific lipid tests like lipoprotein A.
To be more aggressive, basically,
Yeah,
for a
to
patient
be-
that has just risk factors but not necessarily symptoms.
Yes, and so I'm looking at their cholesterol and I'm thinking, oh, well, they have a family history and maybe they use a little bit of tobacco and their LDL, their bad cholesterol is 140. but they're thinking, oh, I think I can just exercise and make that better. And while exercise will decrease that LDL maybe 15%, and they adjust their diet and their exercise, their HDL will go up a little bit, it still may require medication treatment. That's where these other adjunctive specialized lipid tests will then come into play, or where I look at particle size of these bad cholesterols and the LDL particle sizes along with the C-reactive proteins, and then I say, well, you know, you've got a more atherogenic particle that's floating around in your bloodstream.
And by atherogenic, we mean it will cause a plaque.
It's going to cause plaque,
Exactly.
and it's going to be more likely for these plaques to rupture. So then I'm going to tell him or her, you know, you've got a cholesterol panel profile that also looks like you're carrying these genetic things that made your parents get heart disease early. You should be treated with more aggressively with aspirin, cholesterol drugs such as statin drugs, and whether or not we need to do stress testing is the next step. Then we talk about, well, all right, how do you do with your exercise? I mean, what kind of things can you tolerate before you get into trouble?
Now, Howard, I want to go to you on this quick point here, though. How do you talk to your patients about, again, we have trouble just getting them on medications, but when you're talking to them, you're seeing them more of an end-stage issue. How do you get them then, after that point, to get on medications to prevent something else from happening? Or is it more or less that these patients are assigned, they're going to get their surgery, and that's pretty much where they're going to?
Well, we have a frank discussion about what's going on in their case. I find that a lot of patients will not actually even be on a cholesterol-lowering agent like a statin drug when they come to my office. And they'll often tell me, well, I went to my doctor's office and he said that my cholesterol level was fine. But these patients have atherosclerotic plaques within their arteries. And it's what I do is I put them on a statin drug because it stabilizes the plaque. A lot of times, it's not actually the narrowing, but these plaques start to break up, and then blood gets under it and closes off the artery and causes the artery to occlude. That's what happens in the heart. That's what happens in the neck, causing strokes. So the statin drugs have a stabilizing effect on them. So I put all my patients onto a statin drug. I also have them take an aspirin, either a baby aspirin or half an adult aspirin daily. That prevents the platelets from what we say sticking and causing little strokes or mini strokes. And those are the two mainstays of my practice.
Well, I'll find that patients will often take a baby aspirin without really complaining too much. But Bob, how do you convince a patient to take a statin when everybody seems to read something on the internet and says, whoa, 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 these medications cause X, Y, and Z problems. I feel fine. I don't know what you're talking about, but the plaque issue, I don't want to take a statin. And it's difficult because we've all been there. And how do you formulate your discussion with the patient and say, listen, we're not treating the problem today, we're avoiding the problem in the future with this medication. So what's your action? How do you do that?
One way you can do that is if you have, for example, a postmenopausal woman come to you and they have high cholesterol, but they really don't want to take a statin because, you know, statins do have this problem occasionally having muscle aches, muscle weakness, you feel fatigued sometimes, and that happens 5 to 10% of the cases with all statins. Vic mentioned the high sensitivity C-reactive protein. If you have a patient that has high cholesterol and they have high C-reactive protein of the high sensitivity type, then they are exquisitely susceptible to having a cardiac event.
Yep, absolutely.
So that's more fuel for the fire, so to speak, and you can usually talk your patient into taking a statin. Now, the statin intolerance issue usually can be reduced by giving a low dose of statin, and sometimes you can give the statin just 3 times a week, Monday, Wednesday, and Friday, and you go low and you go slow, and you see how much a patient can tolerate. And that's how I do it in my practice, and I have great success.
And I think that's absolutely correct. I mean, I like the fact that you've emphasized that, you know what, we can't get you on 80 milligrams of the high dose statin. We'll start the lower dose one and we'll build our way up because, again, something's better than nothing. I totally agree with that. And I think that, again, I do see a fair amount of muscle weakness and pain. I've had patients take sometimes coenzyme Q, with this medication to offset some of the effects. But Vivek, how do you feel when you have patients who say to you, I won't take a statin, I'm going to go out and take seeds and beans and this and that. I will eat
Red yeast rice.
I will do something, but I actually have patients spending more money on those things than the actual medication.
They actually end up spending more money.
So how do you deal with that when they come in with 20 different supplements, but they won't take the prescribed medication?
Well, I try to work with them, and I want to give them a time frame that we're shooting towards. So I'm going to give them a goal. I'm going to say, all right, we're going to try your way, and if we don't succeed with your way, which may not be the way that I want them in the first place, but I'm going to say, all right, I'm going to give you 6 months to clean up your act, all right? And we're going to try your different things. I may say, all right, give it a try with a red yeast rice extract. Make sure you're on a good dose of CoQ10, 200 milligrams or higher, and then we'll recheck your numbers in a few months, and then we'll see where you are. And we make it's almost like a little contract, a little under the table contract. We're going to try it this way, but if we fail, you're going to listen to me, and you're going to follow my direction, and we're going to go and we're going to pick the drugs that we need to use.
And I really liked what you just said, because I think patients want to be, hey, it's my body. I want to know what I'm doing with it, and I want you to be a partner with me, but I don't want you to tell me what I need to do, because I think a lot of times physicians will say, these are the guidelines, you need to be on this medication, take it. And the patients will say, whoa, time out, I'm not doing that. I listened to this other person who says I can do X, Y, and Z. But I like the fact that you say, listen, we'll meet you halfway. Try it. Let's see if it works. If it doesn't, you do it my way. And that way, the patient understands that, guess what? We're in a partnership. We're building the health together, not having one person dictate it and tell them what the other person's doing is wrong. Right. Because I think we have to take into account there is a lot of other alternative therapies which we're still investigating. So I don't want to tell anybody at home right now that throw out all the supplements, but I would also say take heed of what your doctor is saying, because it's important that we kind of work together on this. Now, Howard, let's switch gears a little bit and let's talk about hypertension. And the fact that hypertension obviously leads to vascular disease as well, but in your specific specialty, PAD, when you see people with high blood pressure that's uncontrolled over time, what is one of the symptoms that you would tell people, say, hey, it's not just pain when you're walking, but what are other of the symptoms of vascular disease that you see most likely related to not having your hypertension or diabetes controlled? What are the other symptoms mainly in your office that you've seen?
Well, one of the high risks is stroke. And with the hypertension, they're going to develop more blockages in their carotid arteries that leads up to their brain. There's a branching of the arteries in the neck, and at that branching point, the arteries develop almost an injury to the artery, and the way they repair is by depositing cholesterol in that area. The higher your blood pressure is, the more at risk you are of having a stroke in that area. And then in the small vessels in the brain, you can develop atherosclerotic plaque in those areas too, and blockages there, giving you another risk for stroke. So that's one of the major problems with the high blood pressure that I see.
And the thing is that, Bob, let's go back to the baseline again. Hypertension. Patients don't like taking medication. So we just addressed statins. How do you get them on blood pressure medication?
Well, first of all, you develop a relationship with your patients. You take yourself away from the computer screen and you face the patient and you explain to them what their risks are for cardiovascular disease, heart attacks, strokes, PAD, whatever, and you develop a relationship and you try and get them to take medication if their blood pressure is 140 over 90 or greater. And it's been proven that if you can lower the blood pressure, they have less risk of stroke, less risk of heart attack, less risk of impotence, erectile dysfunction, PAD, and you have them come back every 3 months to check their blood pressure. And it's been shown that most patients require 3 or more medications just to control hypertension. It's a difficult disease to treat.
But would you agree, guys? It's an unsexy disease, as in people don't look at it as being life-threatening. No one looks at it like, Howard, you brought up stroke. We talked about heart attack, but we didn't really say that, guess what? It's not really cool or sexy to talk about getting your blood pressure controlled. So Vivek, how do you phrase it to someone when they come to see you and you're like, listen, you're not controlled, and they look at you and say, Doc, white coat. I come into the office, I see a doctor, my blood pressure goes up. How do you justify saying, okay, we need to get you on some meds for this?
I asked them to pick up a quality blood pressure cuff from their local drugstore. I send them home with a little spreadsheet, and on that spreadsheet has date, time, blood pressure, heart rate, and any comments they want to say about what was happening when they checked their blood pressure. And then they record it 3-4 days a week. I tell them don't pick any particular time. Sometimes I do, depending on if I'm having issues with the medicines they're on. But I send them home with a log, and I want to see what the trends are. I want them to write the numbers down and forget about it and go about their usual business. So when they bring me those blood pressures back, I can see what kind of comments they had, what their blood pressure was with a certain situation, and then they can tell me whether or not it was truly white coat. You know, they'll tell me, oh, my blood pressure is always fine when I'm at home or if I'm at someone else's place, but when I come in here, my blood pressure is through the roof. And so I'm asking them to prove it to me. And so when they show me the numbers, they're proving it to themselves whether or not they truly have white coat hypertension. So then we have more fuel to then say, all right, yes, I do need to be treated, and this is why.
And I think it's, Howard, going from that point along and going back to Bob's point of the symptoms of uncontrolled hypertension, how often do you see men coming to your office and saying, complain about erectile dysfunction, and finding out that it's a PAD cause, or knowing that's the reasoning for why they're basically having to have some vascular issue that is not a urology issue, but vascular?
Well, again, we tried to explain that peripheral vascular disease, peripheral arterial disease is a systemic problem. And it's not just in the single arteries in their legs and their neck and their heart, and that it affects every organ in their body. And we, again, go back to the basics. We talk about the risk factors. Again, we talk about stopping cigarettes. They don't realize that nicotine actually elevates your blood pressure. A lot of people think it relaxes them, and it actually raises their pressure while they're being, quote, relaxed. Go back to exercise. Go back to lowering their cholesterol levels. And we always end up in the same place. It's the basic foundations, as Vivek mentioned earlier, that we have to get under control. Otherwise, you're not going to solve their issues.
But it's amazing how many patients have come to me complaining more of their ED than their hypertension. You know, that just doesn't seem to be more of their issue.
Well, right, but ED is something they know about. Hypertension is what used to be called a silent killer.
Exactly.
You don't feel your blood pressure.
And that's why we've
elevated.
mentioned how it's not really the sexy diagnosis, because people are like, what do you mean? I feel fine. I have 150/90. Who cares? I feel good. And that's the danger. We're letting the body get used to a higher pressure.
Right, and it's also interesting how over time our definition of high blood pressure has changed too. I think 15, 20 years ago it was 160/90. As we've been mentioning, it's now 140 over
90, and it's coming down.
And it's coming down. And
absolutely. It's
right.
going back in a circle to 120/80, but again, the main issue is getting them to goal. And we've talked about lipids, we've talked about blood pressure. Bob, let's talk quickly about diabetes, if we can do it quickly. But I want you to say, when you have the patient come in and they've never been checked and you're checking them out, what do you look for to diagnose that diabetes in these patients?
Well, there's several things you can do right in the office setting. You can prick their finger and do a random blood sugar and just get a snapshot of what's going on with them right at that moment. You can get a urinalysis at the office and check it for glucose. And there's also something called a microalbumin that you can do right in the office. And if a patient has high microalbumin, which is microscopic protein particles in the urine, you know that this patient is going to be a risk for stroke or heart attack. And they're probably also at risk for end-stage renal disease eventually too. So those are all things you can do right in the office. You can send the patient for lab work, and that's called a hemoglobin A1C. Everybody should have that done. Everyone should know what their hemoglobin A1C is. Anything above 6.4 on the A1C scale is diagnostic of diabetes.
And I like the fact that you just brought up a lot of these things can be done in your office. It doesn't have to be that we send them for complex testing or invasive procedures. Literally, peeing in a cup, a finger stick, we can get a lot of information from that pretty quickly.
That's right. And the other thing I wanted to mention was the white coat hypertension that Vic mentioned. That still needs to be treated because blood pressure is not a steady, continuous type of reading. Blood pressure goes up, it goes down, and I will have patients come and bring me their blood pressure readings, and they'll say, Doc, I don't understand why my blood pressure's high when I come to see you. I just checked it at home and it was 120 over 60.
But I nearly got in an accident on the way over here.
You have to explain to the patient that all the blood pressures that they're checking are correct. And the high ones need to be treated, and that means you got to treat the patient as a whole.
Exactly.
Can I jump in here?
Yeah, of course.
We haven't mentioned the epidemic in the United States is going unmentioned, which is obesity.
Yes,
absolutely.
And being overweight. And I know you probably see many patients with metabolic syndrome. They don't realize that it's what develops into diabetes over time. People don't realize that extra roll of fat on their abdomen, that's actually an organ, and that's actually causing the diabetes and other sequelae of the diabetes.
Right,
that
and
happens over
for all
time.
of you out there, metabolic syndrome is basically pre-diabetes. It means borderline diabetes, and the risk factors are advancing age, advancing weight, advancing blood pressure.
And Vic, when you see that type of situation though, do you feel like, okay, well, we need to kind of get the primary care back involved here, or do you say, hey, listen, I got to manage the cholesterol and the blood pressure? How do you bring it together?
Well, I'm a lot more aggressive with that with this metabolic patient, metabolic syndrome patient, where, I'm more adamant about, we need to start aggressive treatment now. And if you are able to modify your activity and diet such that you lose enough weight that you're no longer a metabolic syndrome patient, so be it. I'll be happy to take you off medicine.
And exercise, we're talking not just like 1 or 2 days. We're talking 5 days, 30 minutes a day of something aerobic.
Yep. Yeah, lots of aerobic activity, 150 minutes a week, and the treatment of even this pre-diabetes and this metabolic syndrome, where we're starting people on metformin, we're starting them on these Genovias and all these different other oral diabetic agents, even though they don't yet even hit the diabetes diagnosis yet. They need to be treated in that metabolic syndrome time frame before they get into full-blown peripheral arterial disease, coronary disease, carotid disease, all from metabolic syndrome, hypertension, and if they smoke, diabetics that smoke have the worst peripheral arterial disease. I'm sure Howard can tell you all about it.
And that's what I was saying, Howard. Yeah. So let's talk about now. We have the risk factors all addressed, or we're addressing them, but unfortunately, you see a lot of patients that have none of them addressed, and they come to you. What do you do treatment-wise as a vascular surgeon for when the patient honestly actually has to have something invasive? What would you do for a person who has a blocked artery in the neck or a blocked artery in the leg, or even an aneurysm in the abdomen, which we will talk about briefly because I know we've done a lot of great work helping these patients. What would you talk about people with abdominal aortic aneurysms?
Well, an aneurysm is a swelling or dilatation of the aorta. The aorta is the main blood vessel leading from the heart down to the legs. We will measure the size of the aneurysm and we'll watch it depending on the size. If it's greater than 5 centimeters, about 2.5 inches in diameter, then we start talking about an intervention. If it's lower than that, smaller than that, we will be monitoring that aneurysm over time, every 6 months to a year, to see if it's getting bigger. And again, we will talk about the risk factors, the hypertension, that will increase the size of this aneurysm, and try to get them on something called a beta blocker, metoprolol, Lopressor, to try to prevent that from growing, keep their blood pressure under control.
And oftentimes we can fix these, do repairs without having to open the belly or do major surgery anymore.
Absolutely. The treatment of aneurysms has changed markedly over the past 15, 20 years, and now we can treat these with a covered stent that would actually relines the aorta, putting a stent into the aorta that prevents the pressure from expanding into the aneurysm sac and diverts the blood down into the legs.
It's amazing. I mean, it's absolutely amazing compared to what 20 years ago, how bloody the surgery was comparatively to what it is now. It's amazing.
Right. Well, it required opening the abdomen from the sternum down to the pelvis and replacing the aorta with a synthetic graft.
Well, and like I said, amazing how technology has changed, and Vivek, even in our field of interventional cardiology, so tell the audiences watching, so when a patient has a heart attack in the hospital, what's the process? What goes on?
Well, it's become so streamlined and efficient now. Just since I was back in training 15 years ago, the time frame in which this all happens. But it's when they first get to the emergency room, hopefully by ambulance, because that actually speeds their time to treatment. They get their EKG, and within a few minutes, the cath lab team is activated and ready to go and get started. So we get them from, after their EKG is abnormal, they've had some blood work done, assessed their symptoms, they're heading to the cath lab. The cath lab team is organizing, and then the procedure involves putting a tube into the artery, and it's usually one of these peripheral arteries, like the wrist or in the leg, on top of the hip bone, the common femoral artery. We'll put a tube in, and then through that we can then put smaller catheters, basically long-shaped straws that we can put contrast in the arteries and take X-ray movies, these coronary angiograms. And we take them from a couple of different views, identify the culprit artery, and then open it. And the way we open it is with thin wires and balloons to restore blood flow first, and then scaffold the artery with a stent.
Well, Vic, that's like at the level of the heart attack. Let's take it back a little bit to the patient who comes to the office complaining of chest pain. Before running to the cath lab, what do we do? What would you do in the office prior to that for a stable patient who complains of pain when they're walking?
Okay, so that's a different, on the same continuum of coronary artery disease, now we're talking about a patient with more stable coronary artery disease or stable symptoms, as opposed to the person who comes in with the heart attack. So in that stable patient, I'm assessing them again with history and physical, EKGs, and then we're going to talk about stress testing. And we're going to talk about different types of stress testing to kind of, bring out whether or not they're having enough heart muscle at risk with either changes on their treadmill stress test, or the nuclear pictures, the echo pictures that we take, and shows a large chunk of heart muscle at risk. Depending on how much myocardium's at risk there is where we're going to decide about treating invasively versus treating medically at first, and then how severe their symptoms are.
And that's great, because you take the patient, the symptoms, and then you take the test and you put it together. As I tell every patient, we treat the patient, not the test. The test might be abnormal, but if the patient isn't having any issues, you take a step back and say, maybe it's a false positive. Maybe there's something about the test that is not correct, that we have to take a step back and look at the patient as a whole again. Now, Bob, we talked about the lipids, the blood pressure, the diabetes, the smoking, but how about, a little bit we touched about the exercise, the obesity issue, but diet. What type of diet are you telling most of these high-risk patients who have all the risk factors, and we're medicating them, but how do you get them to eat right?
In the past, we've focused on a low-fat diet, but now we're more focusing on a low-carbohydrate diet.
Yep.
Because the carbohydrates, when you eat them, they turn into sugar as soon as they pass through the liver. And we know that diabetes or prediabetes is a huge risk factor for all cardiovascular disease. So I focus more on lowering the carbs and actually putting patients on more lean and green and avoiding the grains, the flour, the corn, the sugar.
Yep, the white flour, the white pasta, especially.
Because
right?
those tend to be more atherogenic, in my opinion.
And I think data is supporting that. I think also what we have in this country is a portion size problem. People just don't know how to portion size.
Right.
And Howard, do you see this often? Obese patients coming in with this vascular disease, and you say if you were 150 pounds, 200 pounds lighter, we might not have seen this process?
Well, right, and I don't try to hit them over the head with telling them they're 100 pounds too overweight, but it's amazing what losing 20, 30 pounds will do for a person's just general well-being and their feeling about themselves. I try to tell my patients to walk around the outside of the supermarket and not go into the center aisles, because the center aisles are where all the carbohydrates are actually stored. Stay in lean and green, stay in the produce department.
It's amazing how marketing is performed in the supermarkets, but that's correct. You're absolutely right. By walking around, they're avoiding, hopefully, the temptation of getting those high sugar, high calorie products,
Right.
which have really low nutritional value. Now, Vivek, how about yourself? Do you have any suggestions about dietary issues with the patients when they come see you?
You'd mentioned the weight loss, so I wanted to hit that quickly, but when the patient does lose 20, 25 pounds, they generally lose a blood pressure medicine. So if they want to get
And a
off of the
diabetes medicine, too,
and a
sometimes.
diabetes
That's a great point,
medicine.
guys. Great
You know,
point.
you lose
Yeah.
20 pounds and bam, you're losing medicines, and they're where they wanted to be in the first place, was not taking medicines.
Isn't that a great
So-
way to
Yeah.
kind of, I hate to say sell it, but that is. You tell someone you can get off these meds.
Well, it's
And-
actually been shown on these very obese patients who have bariatric surgery
Yes.
that when they lose that 100 pounds, that they actually come off their diet. Their diabetes can be cured with weight loss.
And it is so true when you actually tell these patients that you will be removed from all these prescriptions, or potentially some of them. It's a big selling point. I really think it's a positive. But I would tell you at this point in time, guys, we have really covered a lot of great topics today. So what we're going to do, guys, we're going to finish up with some final comments. I'll start with Vivek. Why don't you start here and give us some final comments about heart and vascular that you want to let the public know that you'd like to take as a take-home message.
So things that we have to do to minimize your risk: don't use tobacco or anything like it. Take your aspirin if you need to. Make sure your cholesterols are well controlled. Eat healthy. 150 minutes of aerobic exercise per week.
Howard?
Healthy lifestyle, exercise, weight loss, and avoid the use of tobacco.
Absolutely concur with that. Bob?
Reducing your risk of cardiovascular disease actually starts with the primary care physician, and unfortunately ends with you guys sometimes. My job is to see to it my patients don't really need you to do a cardiac cath or to treat them in the hospital for a heart attack. So my job is to lower cholesterol, lower the weight, and even if you can't lower the weight, if you can get a patient motivated to exercise, even obese patients that exercise have a 50% reduction in cardiovascular disease. So it's important to get people to exercise, even if they're overweight. I have patients always coming to me and saying, I exercise every day, 30 to 40 minutes, I just can't seem to lower my weight, but I just encourage them to continue doing that, because those patients are less likely to have to see you for an aneurysm or PAD or a heart attack or carotid artery disease, which, by the way, every patient should be screened for carotid artery disease with an ultrasound. Every Medicare patient can have an aortic
Absolutely,
ultrasound.
I agree.
It's covered by Medicare. So if you're 65 years or older, get your primary care doctor to do an aorta ultrasound to screen for aneurysm.
And you know what, as we've all seen, especially the panel sitting here, the aneurysms don't tell you before they rupture. They sometimes happen,
Right.
and you have no idea.
And also, if your patient does have high cholesterol and they don't want to take a statin, do an high sensitivity CRP test. It's simple, it's cheap, and if it's high, then that gives you more reason to really
More
encourage
ammunition.
the patient to be on the medication that they really need.
Well, you know what? I love the comprehensive approach, guys. I really do, because especially because we have invasive physicians on the panel. And you know what? I'll be honest. I think a minute part of the talk today was about doing procedures. The whole section pretty much was talking about preventative medicine. And I love that, because I think the public will really appreciate watching that, hey, you know, we could put stents in, we could do bypasses, but we'd rather you just take your medication and avoid the hospital altogether. All right, guys, thanks a lot for being here. Thank you all to my guests for joining us today. As we have discussed here today, the bad news is that heart disease is the largest killer of people in the U.S. The good news is that heart disease has become one of the most carefully studied health problems. More is known about the causes and prevention of heart attacks than most other deadly diseases. That is truly great news, since what has been learned allows us to assess the risks brought about by our lifestyle and to know what we can do to reduce these risks of dying of heart and vascular disease. Thank you so much for joining us for this special episode. As always, Remember, a positive mind is a positive body. We'll see you next time on the Pulse of Manatee.